Richard Gamubaka is my name. I'm a CHESA fellow alumni. Yeah, I'm from Mbale Regional Referral Hospital. I'm currently a fellow in the College of Surgeons of East Central and South Africa. I'm pursuing surgery, general surgery first, but with passionate in pediatric surgery. Yes, I think that is the few things that I can talk about myself. Yeah, actually now this one cuts across when we talk about the burden of surgery, and that is one of the reasons why I'm vying to become a pediatric surgeon in the region where I'm working, in the far east of Uganda. We face the same problems or challenges. We have no pediatric surgeons. The same thing which was happening to my sister. Right now they are the number of doctors have increased a bit, but still they are still low coverage for all the doctors, despite that the number of doctors have increased. So like for example, the reason why I'm vying to become a pediatric surgeon, in far east, we don't have pediatric surgeons there. And these are people who in one way or the other, in most cases, they have their first time to come to the hospital, especially in the Mbale Regional Referral Hospital. They even fear. That is their first time. And if they come to Mbale Regional Referral Hospital with, for example, a child with a congenital anomaly, the gut is out, is having anatrasia, is having old duodenal atresia or omphalocele, first of all, they are terrified. They don't know what to do next. Now, when they come to the hospital, Regional Referral Hospital, we don't have pediatric surgeons, and they are again referring them to the city, which is about 200 kilometers away from their home. It also bothers them a lot because, first of all, in most cases, they are families with young children, and the mother and the father, plus this current one who is having a congenital anomaly, is being sent to a regional referral hospital, and again from the regional referral hospital is being referred to the city. And normally when they talk about Kampala, they think they are going to get lost in Kampala, because even that is their first time to come to Mbale. They are far from the deep villages in the region. So they also think about the time they are going to spend in the city, vis-a-vis who is going to take care of the young ones left at home. So they find it a big challenge, and what they do, you give them a discharge form. This one I've witnessed this several times, not once, not twice. You give them a referral form to where we think they will be helped in the city. Getting out of the hospital gate, they just go home and they say, it's okay, let us go and wait for the inevitable to occur. We shall give birth to another one. And that's what they have been doing. Yeah, so this one has opened up some of us, our minds, that now we need to help to specialize in this, and then we do help those ones who can't go to the city. And that's what we are doing. So we started doing, I'm a medical officer currently, but a resident. So we have been operating on those young children, those ones who can't afford to go to the city. Because first of all, even our referral system is not all that good. They fear who is going to be contacted where you are referring them. The transport, the food and all that. When you look at all those things, and this is a family which is living below the $1 per day, so they end up just going home and waiting for the inevitable to come. So that's the reason why some of us are coming up. If we specialize in some of these we can say disciplines which are not be populated a lot, yeah, we can also save our community. Yes, that's the reason why we are here. I will tell you, I have not faced so many challenges in the program. Instead, the experience I've gotten that the program has helped me to become a leader, that's number one, and then to overcome certain challenges. Because I was in my regional referral hospital where I work, I was I was elected as not elected, but I was appointed as the team lead for failure to rescue patients. That project is ongoing. But trust me, my major challenge was bringing the senior consultants, the consultants, and even the juniors, the nurses all together in our bi-weekly meetings. Sometimes you would even go and tell them face to face, please, we have a bi-weekly meeting where we have to evaluate on how after the 2 weeks have gone, how we have managed our patients, how many have we lost, and then we do some audits on certain patients so that we keep on improving on the outcome of the patient. Of course, with data, because we have that project entails assessing the patient, grouping them into high risk and low risk. The high risk patients using the ASOS score are taken to high dependence unit, HDU, and then ICU. The low risk are taken to ward, but of course still the monitoring continues as normal, as usual. And this project is not introducing something new. We are using the real things which were there before, even which are done in medical school, like taking simple things like taking BPs, pulse, respiration, the vitals generally, temperatures of patients before surgery and then after surgery. Then we evaluate. So if you see that, for example, some parameters are high, it rings into your mind and then you call the necessary person. As a nurse, you call the intern on duty, then the intern calls the medical officer. The medical officer with the senior house officer call the surgeon who operated, but still also the surgeon who is on duty at that time is in the know of that, yes. But my major challenge was bringing all those people together and then telling them that, look here, you're a surgeon, you need better outcome for your patients. Yeah, that was my major issue, because at the beginning, people were sluggishly moving, coming in and out, and then talking somehow not good. But I thank CHESA because I kept on discussing with my mentors, and they would always give me courage. Don't lose hope. Maybe you need to walk into such and such office, like the SPNO's office, that is the lead of nurses, and then have a discussion with the patient, with the lead of that nurse, or the nurses in the hospital, or even in your department. Walk in the head of department surgery and have a discussion one-on-one, and let them know why you are doing that. Because if you don't explain to them, maybe they are doing because they don't think that is matter. But at the end of the day, up to now the project is still on. It is even the head of department, those senior people who are even always asking, when are we having a meeting? And everyone has come up. So our hospital is a pilot study. So it will go on. If we have good results of our patients' outcome, then it will be expounded to even other hospitals. And the people who are going to train those people are the nurses and the surgeons. So I have learned a lot. I've been patient, as my mentors in CHESA have been always telling me. You talk to Professor Doruk, he tells you, please do this and this. You talk to Dr. Bua, he also tells you what to do, how to handle. You talk to Dr. Adam. Dr. Adam is one of our best anesthesiologists in the region, and is a very good mentor in terms of research. And this one also comes back to what we have been discussing today, research collaboration, leaders versus mentors versus a person can have so many mentors. Mentors. And the mentors should not personalize the mentees. Yes, that is what it is. Because now, like me, I have so many mentors, and I'm very happy that they don't personalize a person like me, that that one is mine. No. When I'm challenged, I know who to go to. When I'm challenged, I know in different situations, in research, in surgery, in pediatrics, in leadership, and also family issue also, yeah. So CHESA has really helped me a lot, and I hope more so as a fellow to continue working with CHESA, and then probably I also start mentoring some people in CHESA.